All right, everyone, welcome. Today we're going to do a deep dive, a really high-yield clinical review into something we all grapple with, hospital-acquired pneumonia, or HAP. This is one of those infections that's a huge driver of morbidity and mortality in our hospitals. So it's absolutely crucial we're all on the same page.
So here's our game plan. We're going to walk through this just like you would in a clinical setting. First, what exactly are we talking about? Then, how do we diagnose it and figure out the bug? We'll cover the usual suspects, how to treat them, how to prevent this whole mess in the first place, and finally, what happens when things go wrong.
Okay, first things first. Section 1, Defining Hospital-Acquired Pneumonia. Let's make sure we're all working from the same foundational understanding.
So, what is HAP really? The definition hinges on one critical detail, the timeline. We're talking about a pneumonia that was not there when the patient came in. It has to pop up 48 hours or more after admission. That's what makes it a true hospital-acquired or nosocomial infection. And make no mistake, this is a major player globally when it comes to what makes our patients sick and, unfortunately, what contributes to mortality in the hospital.
Now, take a look at this data. It really paints a picture, doesn't it? The mortality rate for men is almost 20 per 100,000. For women, it's under 7. That's a nearly threefold difference. So you have to ask, why? Well, one of the leading theories points to lifestyle factors, specifically the historically higher rates of smoking among men, which we all know is a huge predisposing factor for any kind of severe pneumonia.
So who's most at risk here? Well, it's not just one thing. HAP is really multifactorial. You've got patients with underlying lung disease like COPD or those who've had a stroke. But then there are the hospital-specific factors, right? Just being in the ICU jacks up the risk. And if a patient is on a ventilator, that's a whole specific subtype we call VAP, or Ventilator-Associated Pneumonia. Add in a weakened immune system or a high risk for aspiration, and you've got a perfect storm for developing HAP. Okay, so we suspect HAP. Now what? Let's move into Section 2, the diagnostic side of things. This is where the detective work really begins, because finding the right bug is everything when it comes to choosing the right drug. All right, the diagnostic workflow. Where do we start? Usually with a sputum sample. A simple gram stain can give you a really quick, valuable first clue. But for our really sick patients, the ones in the ICU, getting a good sputum sample is often a no-go. That's when we have to be more invasive and get a direct sample from the lower airways. Think a bowel or a tracheal aspirate. And you absolutely cannot forget blood cultures, especially in severe cases. Finding bacteremia changes the game completely. Okay, time for a quick test question. You've got a 72-year-old ICU patient. You suspect HAP, but they can't cough up any sputum. What's your next move to get a good sample? Let's think it through. A nasopharyngeal swab? That's really for upper respiratory viruses. B, blood cultures only. Important, yes, but they could be negative. C, urine antigen? Great for Legionella or pneumococcus, but not a broad screen. The correct answer here is C, bronchoalveolar lavage. To know what's really growing in the lower airways, you have to go get it. A BAL is the gold standard for getting high-yield, relevant material for culture. All right, we have our sample. Now, what bugs are we hunting for? That brings us to Section 3, the microbiological landscape. And this is where we tackle that age-old question, is it an infection or just colonization? So here are the usual suspects in adult HAP. You can see Staph aureus at the top of the list, followed pretty closely by Enterobacterales and the infamous Pseudomonas aeruginosa. But here's the kicker. Look at that huge slice of the pie. Over 50% is other or unknown. That right there tells you just how difficult this can be. A lot of the time, we're flying a bit blind, which makes empiric choices so important. And speaking of Pseudomonas, I'm sure every clinician listening can appreciate this one. Pseudomonas aeruginosa is like that one friend who's always intrinsically resistant to your plans, and when you try to broaden your approach, they just acquire more resistance mechanisms. It's funny because it's painfully true, right? This bug is just notoriously difficult, constantly finding new ways to outsmart our antibiotics. It's a massive challenge. And the challenge gets dialed up to 11 when we're talking about multi-drug resistant organisms, the MDROs. We're talking about MRSA,
ESBL-producing Enterobacter and the big guns of resistance, carbapenem-resistant Pseudomonas and Acinetobacter. When these show up on a culture report, your therapeutic options just shrink dramatically. It forces you into a corner where you absolutely must rely on susceptibility testing.
Which, of course, brings us to Section 4, treatment. How do we actually manage these patients? It's a two-step dance, really. You start broad with empiric therapy based on risk factors and what bugs are common in your hospital. Then, once you get that culture data back, you de-escalate to a targeted, smarter therapy.
So let's look at a few examples of that targeted therapy in adults. If you're lucky enough to find a plain old penicillin-sensitive strep pneumo, you might get away with simple amoxicillin. If it's MSSA, you're likely reaching for something like flucloxacillin. And for Pseudomonas, you're breaking out an anti-pseudomonal agent like ceftazidime. But I have to stress, these are just textbook examples. The real world is all about your local antibiogram and the specific susceptibilities of your patient's bug.
Okay, let's switch gears for a second and talk about kids. Specifically, neonatal HAP. So for a newborn who gets pneumonia more than 48 hours into their hospital stay, the bug list you're worried about is a bit different than in adults or even older kids. Your top concerns are going to be S. aureus and those gram-negative rods, the Enterobacterales family.
All right, another quick case. You have a 3-month-old diagnosed with HAP. What's the pathogen you're most concerned about, and what's your go-to empiric therapy? Let's break it down. Are you thinking about atypicals like mycoplasma? Probably not in this age group with HAP. The real heavy hitters we're worried about are S. aureus and gram-negatives. So you need to cover both. That makes answer C, a combination of cefuroxime and gentamicin, the most logical empiric choice to start with.
You know what they say, an ounce of prevention is worth a pound of cure, and that's never more true than with HAP. So Section 5 is all about prevention and control. How do we stop this from happening in the first place?
Here's something interesting about the bureaucracy of it all. HAP itself isn't generally a notifiable disease. But some of the bugs that cause it are, especially if they cause invasive disease. So if your patient's HAP is caused by invasive Haemophilus influenzae type B or invasive group A strep, that's a mandatory report. But if it's, say, Chlamydophila pneumonia, that's usually not reported unless you're dealing with a big hospital outbreak.
So what does prevention actually look like on the ground? Well, it's a mix of things. It all starts with the basics we drill into everyone. Wash your hands. And, basic cough etiquette. But it scales up to bigger system-level strategies. We're talking about cohorting patients with the same infection, making sure our high-risk folks are up to date on their flu and pneumococcal vaccines, and even using targeted prophylaxis like STD in very specific ICU settings.
And that brings us to our final section. What happens when, despite everything, things go south? We have to talk about the complications and the clinical aftermath of HAP. Knowing what to look for here is absolutely critical.
We can really split the complications into two buckets. First, you've got the problems that stay in the lungs, the pulmonary issues. This is things like a pleural empyema, which is basically a collection of pus around the lung, or a lung abscess, or the dreaded ARDS. Then you have the systemic problems, where the infection spills out into the rest of the body. We're talking bacteremia, leading to sepsis and septic shock, which carry incredibly high mortality, and even downstream effects like cardiac and neurological problems.
Okay, last question for you. Your patient with HAP now has a collection of pus in the pleural space. What do you call that, and what's a common culprit? Well, the definition of pus in the pleural space is a pleural empyema, so we can narrow it down. And while a lot of bugs can cause this, one of the classic pathogens to do so is Streptococcus pneumonia. It just loves to spread from the lung tissue right into that pleural space. So the answer is C.
So, we've walked through the whole story of HAP, from what it is to how it can unfortunately end. But the bacteria aren't sitting still. They're evolving. And that leaves us with this final, really critical thought to ponder. As these multi-drug-resistant organisms keep getting smarter and tougher, are the playbooks we're using today going to be enough for the next decade? That's the question that should keep all of us in clinical practice and research up at night.